Hacemos formal. Buenas tardes a todos. Es para mí un placer y un gran honor que Fabián Lerner me haya dado la posibilidad de presentar su nuevo libro, Glaucoma. Fabián no necesita ningún tipo de presentación, simplemente aclarar que Fabián es actual profesor titular de la Universidad de Favaloro y es presidente de la Asociación Mundial de Glaucoma. Posiblemente Fabián en la actualidad sea uno de los oftalmólogos de mayor prestigio a nivel mundial y creo que todos los oftalmólogos argentinos y en especial los especialistas en glaucoma deben estar agradecidos y deben de estar también, no sé qué palabra utilizar, pero deben sentirse honrados por ser Fabián quien lo representa frente a toda la comunidad de glaucoma mundial. Lo acompañan a Fabián en la realización de este libro el doctor Julián García Feijó, otro especialista en glaucoma distinguido y reconocido a nivel mundial. El doctor García Feijó es catedrático de la Universidad Complutense, jefe del servicio del Hospital San Carlos de Madrid, España. Y también forman parte de los editores del libro el doctor Luis Pablo Julves. El doctor Pablo Julves es catedrático de la Universidad de Zaragoza y jefe del servicio de oftalmología del Hospital Miguel Servet de Zaragoza, España. Creo que entre los tres reúnen a los más distinguidos especialistas en glaucoma y han realizado una obra realmente muy importante, obra que cuenta con 5 sesiones, tiene una sesión de ciencias básicas, una sesión de diagnóstico, una sesión de formas clínicas de glaucoma y a mi entender las 2 sesiones más interesantes, la de tratamiento médico y tratamiento quirúrgico. Así que quiero públicamente felicitar a Fabián por el esfuerzo. Los que alguna vez escribimos algún libro sabemos el esfuerzo y lo que significa la realización del mismo. Así que Fabián, felicitaciones por este merecido éxito. Fabián me pidió compartir este momento con algunos colegas y amigos que lo han acompañado a lo largo de su carrera como médico. Así que vamos a escuchar la palabra del doctor Patricio Schlotman, del doctor Martín Charles y del doctor Roberto Ebner. ¿Podemos pasar el video, por favor?
Buenas, es un placer para mí participar de la presentación del libro del doctor Fabián Lerner. Este es su nuevo libro y conozco a Fabián hace muchos años y sé muy bien de su obsesión por la perfección, su capacidad científica, sus relaciones internacionales y su pasión por todo lo que hace. Y todas estas cosas que describo de Fabián se ven perfectamente plasmadas en este libro. Este libro tiene además otros 2 editores, además de Fabián, a quienes también tengo el enorme placer de conocer, que son el doctor Luis Pablo Julves y Julián García Feijó, especialistas y catedráticos, cada uno, Julián en Madrid y Luis Pablo está en Zaragoza, con enorme capacidad, gente que ha publicado muchísimo, que ha investigado muchísimo, que tiene equipos de trabajo muy grandes y con una enorme capacidad. El libro tiene varias características que lo hacen casi único. Una de las cosas que a mí más me gusta es esta capacidad que tiene de ser para todos los gustos, los que les gusta el libro y tenerlo y sentir el papel, y los que les gusta tener una modalidad electrónica para llevarlo siempre consigo. Más que un libro es casi una enciclopedia. Tiene editores conocidos con una enorme capacidad científica. Tiene una cantidad de autores dentro de Argentina y varios autores del resto del mundo, llegando incluso a personalidades del más alto nivel científico en el glaucoma, por ejemplo Robert Weinreb y varios otros referentes mundiales que están participando con capítulos en este libro. Tiene argumentos académicos sólidos este libro y es lo que lo diferencia de tal vez algunas otras publicaciones que tienen opiniones o tienen tendencia, pero no tienen argumentos sólidos para hacer esto. Y una de las cosas muy interesantes que tiene es que uno puede ver que las referencias de este libro están súper actualizadas, teniendo las clásicas, que es lo que dan origen a la comprensión del glaucoma, pero información nueva y fresca, que muchas veces los libros están sumamente desactualizados. Tenemos referencias de 2019, casi en este libro, de mitad de 2019 hay referencias en este libro. El contenido abarca todo, desde las ciencias básicas hasta la clínica, diagnóstico, tratamiento clínico, tratamiento quirúrgico y además relevación de toda la tecnología que involucra cada uno de estos pasos. La presentación es de una calidad excelente, una presentación excelente de calidad y, como les decía, lo puede tener en libro o lo puede tener en la versión electrónica, y eso es un valor importantísimo para los libros, para poder tenerlo en el consultorio cuando uno quiere ver las imágenes y también tener una disponibilidad rápida para releer esto cuantas veces uno quiera. Es básicamente, podríamos decir, una enciclopedia portátil que sirve tanto para aquel principiante que quiere dar sus primeros pasos en el glaucoma, como para aquel especialista que quiere explorar alguna zona del conocimiento del glaucoma que aún no haya alcanzado por completo. Excelentes autores, excelentes editores, y el producto final no puede ser nada más que una obra de excelentísima calidad científica. Felicitaciones, Fabián, y felicitaciones a los demás editores por este excelente libro.
Es un placer y un honor para mí presentarles el libro Glaucoma, escrito por los prestigiosos doctores Fabián Lerner, Julián García Feijó y Luis Pablo Julves. Conozco de hace más de 20 años al doctor Fabián Lerner, actual presidente de la Asociación Mundial de Glaucoma, y doy fe de su solidez, tanto en la consulta clínica diagnóstica como así en la práctica quirúrgica, y siempre percibí detrás de un excelente profesional y una gran persona. Este libro define el futuro del conocimiento y el manejo del glaucoma. Un libro escrito en español con la colaboración de 130 médicos especialistas y referentes en la subespecialidad. Todos trabajaron minuciosamente para brindarnos esta importante obra de un gran nivel, completa, práctica y sumamente actualizada, con el objetivo de ayudar al profesional con el cuidado del paciente. Teniendo en cuenta la constante expansión del conocimiento del glaucoma, reconocemos que es muy difícil llevar adelante esta obra que manifiesta conocimiento, tiempo, búsqueda y análisis de publicaciones actuales. Incluye numerosos avances en estos últimos años, teniendo en cuenta la constante evolución del conocimiento del glaucoma. El libro se organiza en 5 secciones, con 66 capítulos en total, que abarcan desde la ciencia básica, diagnóstico y tipos clínicos hasta el tratamiento médico y quirúrgico. Presenta fotos de excelente calidad, gráficos, tablas y algoritmos que hacen la lectura un proceso práctico y agradable. Creo que es un excelente aporte para los médicos oftalmólogos generales, médicos en formación en oftalmología y especialistas en glaucoma. Felicito a los autores.
Una nueva herramienta ha llegado a la literatura hispanoparlante en el tema de la hipertensión ocular. El libro Glaucoma de Lerner, García Feijó y Julves es una obra importante que a lo largo de 66 capítulos abarca de lo básico a lo complejo, de lo clínico a lo quirúrgico, de lo confirmado a las hipótesis, dejando así la puerta abierta a la evolución de aspectos por venir en este territorio. Moderna en su presentación, el libro impreso, ebook y otros formatos digitales es una herramienta que llega a ocupar un lugar de relevancia en el conocimiento y consulta del mundo del glaucoma. Glaucoma. Muchas felicidades. Fabián.
Incontables, cantidad de archivos bajados de Google Drive, cantidad de imágenes y escritos. Y la verdad que trabajar junto a Julián y a Luis ha sido un placer. Tanto Julián García Feijó como Luis Pablo Julves son brillantes oftalmólogos, excelentes personas, y una obra digamos, de factura compleja no fue difícil de hacer justamente debido a lo buenas personas y profesionales que son. Muchas gracias, espero que les guste y los ayude en la práctica y el cuidado de nuestros pacientes con glaucoma. Buenas tardes. Bienvenidos al Simposio Glaucoma, el futuro es hoy. Es para mí un gusto y un honor presentar este simposio y coordinar este simposio junto al doctor Héctor Fontana, presidente de la Asociación Argentina de Glaucoma. Héctor, muchas gracias. Este simposio está distribuido y está dirigido al oftalmólogo general y también al especialista de glaucoma y cuenta con la participación de importantes disertantes extranjeros. Difícilmente van a encontrar un verdadero Dream Team como el que van a ver hoy. Disfrútenlo y luego de ver las presentaciones, lo que vamos a tener es una pequeña mesa redonda con el doctor Ignacio Lischinski desde Tucumán y la doctora Ana Sansó aquí en Buenos Aires para hacer hincapié en algunos puntos importantes de las presentaciones que van a escuchar. Muchas gracias. So it is my pleasure to introduce the next speaker. It's Kawe Mansouri. Kawe is Assistant Professor of Ophthalmology, Chef de Clinique at the Department of Ophthalmology, University of Geneva, Switzerland. He is also a consultant ophthalmologist at the Montjoie Clinique, and he is the Assistant Executive Vice President of the World Glaucoma Association. Kawe is gonna talk to us about what is new in continuous 24 IOP measurement. Kawe, thank you very much for joining us in celebrating the first 100 years of the Argentinian Society of Ophthalmology. It is a pleasure and an honor to have you here.
Well, thank you, Fabian. And let me start by thanking Drs. Fabian Lerner and Dr. Fontana for the kind invitation to speak here. It's a distinct pleasure to give this presentation at the Centenary Symposium of the Argentinian Ophthalmological Society. I will be speaking about 24-hour IOP monitoring in glaucoma. I have two relevant disclosures. I'm involved as a consultant with two startup companies active in this field. Of the three pressures relevant to glaucoma, intracranial pressure, perfusion pressure, intraocular pressure is the only one we can currently treat and modify in glaucoma. It is, however, not just a treatable, but a highly unstable parameter, which we do not measure appropriately. And it was no one else than Hans Goldmann, the founder, the inventor of the eponymous applanation tonometry, who described its many shortcomings. First and foremost among those is the fact that Goldmann applanation tonometry provides a mere snapshot of IOP. We measure IOP for a few seconds every 6 months or so on average when patients come to our clinic during office hours. Yet we know that IOP is highly dynamic. It changes from second to second, minute to minute, depending on what you do, what you eat, how you feel, what you wear, and so on. Even this talk can change your IOP. So it doesn't come as a surprise that studies show that we miss peak IOP, which we believe is related to glaucoma development and progresses in probably over 2/3 of our patients. As a consequence, axonal injury due to glaucoma occurs in at least 50% at pressures that we consider to be physiological or even low. One reason is that contrary to these beautiful animals from the San Diego Zoo, we do change our body position. And we go from the sleeping to the wake position. And studies have shown that in all kinds of subjects and patients, young healthy subjects, older healthy subjects, and glaucoma patients, the highest IOPs on average are measured during the nighttime, during sleep mostly. Yet, these averages do not necessarily reflect individual circadian rhythms and IOP behavior. Therefore, having devices that allow us to obtain a 24-hour IOP monitoring or a continual long-term IOP monitoring have been sought for many years in glaucoma and ophthalmology. Two approaches which I will mention here and for which clinical trials are available and or published go either through the non-invasive extraocular route through a contact lens or can be implanted into the eye. Let's have a first short look at the devices that go through contact lenses. Well, I'm sure many of you have heard about the triggerfish contact lens from Switzerland. It has been around for about 10 years. This soft silicone contact lens had strain gauges embedded in it, which measured not IOP directly, but changes of ocular circumference, which we believe reflected IOP changes. And then as we found out more and more, also reflect changes of intraocular volume, which is different from pressure, and are to a big extent dependable on the ocular biomechanical properties. The problem with this device was that the measurements were not provided in mercury, but in millivolt changes. However, there was a lot of excitement. This was from The Economist in 2011, ages ago. And bench testing initially showed a very clear correlation between manometry IOP and measured IOP by the device. However, as we got more and more data, we found out, of course, and happily, that the device was safe, was relatively repeatable. However, its clinical use was difficult. Clinicians, when they obtained something like that in one patient after 24 hours, could see at what time the highest peaks would occur relatively. But again, what did it mean in mutant mercury? We did not know, and therefore it was hard to use clinically. Nevertheless, the FDA in the US approved the device about 5 years ago or so for clinical use. However, it was approved to be used as a prescription device to detect patterns of variation IOP over a maximum period, which then could help to identify the window of time to measure IOP by conventional methods. Well, it turns out the window of time is usually at nighttime to verify with IOP. Therefore, this formula that FDA provided did not turn out to be clinically feasible. Now, when we look at implantable devices, there is one device where clinical data have been published in humans. It's produced by a German company called Implandata. The device, the iMate, has been approved in Europe for more than 5 years. It uses, in essence, pressure sensors like those that exist in car tires, miniaturized. Those are implanted during cataract surgery into the sulcus. And then the patient has a handheld device outside the eye to measure whenever he wants by clicking on the device IOP to obtain a measurement, and then it sends power back to the device. The device doesn't contain a battery. The first results were published in 2015 and showed in some patients a very good correlation between Goldmann implantation measures that you can see as a blue line, and in red, the iMate measures. In other patients, there was more variability for different reasons. Importantly, the device was relatively safe, even the first generation of it, although in 30% of eyes, pigment dispersion during implantation was observed. We found out that had more to do with the wrong surgical technique and recommendations by the manufacturer. Did patients like it? Well, the study duration was only for 1 year. It was for 1 year, where patients were asked to obtain measurements at least 4 times a day. And as you can see, this reflects the measurement frequency. And in the yellow, here you see the yellow part of the bar shows you that about 56% of patients obtained between 3 to 5 measures a day. Once the study was over, there were no clear guidelines. Patients happily continued to measure the device, which showed that they gave importance to the ability to self-monitor IOP at home beyond the study duration. And among different questions asked, it turned out that having the ability to measure IOP motivated patients to use the eye drops more. So that's an important finding. Patients have better adherence if they are empowered, as it seems, to measure IOP. And they felt much better. They felt less worried about missing IOP, potential IOP peaks. So that improved quality of life. The comparison to Goldmann was quite good. Using different statistical methods, there was somewhere between 78 to 88 correlation between GAD and iMate, although you might even argue that having the device in the eye probably obtains a better value of real IOP than some transcorneal device. These are values from one patient throughout about 3 years of measurement, and you see how on any given day IOP can vary from somewhere around 10 to 20 millimeter mercury in a well-controlled glaucoma patient. So you see how variable it is. We look at different aspects of having so much measurement. For example, in the same patient, we found that on average, after 3 years, the highest IOP measurements were at 4 in the morning, as you can see on the graphic on the left side. Interestingly, then we compared these measurements to other studies previously with the contact lens sensor or in the sleep laboratory in San Diego. We see that very often peak IOP occurs somewhere between 3 to 4 a.m. when patients sleep normally. Is there a weekday pattern? Well, another question we're interested in, for example, is IOP low at weekends when patients tend to be more relaxed? Well, here, for example, in this one patient, it wasn't during the weekend. But on Wednesdays, IOP was significantly higher than all other days. Why, we don't know. Then we use the big data that now we have from 22 eyes that had this salvos-based device. We obtained a total of 106,000 measurements, which corresponded to almost 5,000 measurements per patient, over 15,800 measurement days, an average of 718 measurement days per patient. We looked at the mean IOP, we looked at the peak IOP, and we found no weekday effect. However, when we looked around at seasonal effects, winter versus summer, autumn versus spring, it turns out that interestingly IOP is significantly lower during summer. This is a finding that had been suggested by previous studies obtaining a few measurements per year. So we see on average this patient group a clear seasonal effect. However, something that may be relevant for population studies or even maybe for clinical management decisions. Now, the first device is limited to patients undergoing cataract surgery. Patients who have glaucoma, who require glaucoma surgery, would not necessarily benefit from this device, and therefore the same technique was used in a different shape of implant, a rectangular implant to be implanted during non-penetrating glaucoma surgery into the suprachoroidal space, which is a space we often create during this type of surgery. The device is 3.5 in width and 7.5 millimeters in length. Here's a video. I'm going to jump over it because it's too long. Here we start our regular deep squeezing surgery. This was the first case we implanted in Lausanne. So you proceed as you usually do. You open the superficial skull flap. Here we are dissecting the deep skull flap. So far so normal, 5 by 5 millimeters for the superficial flap. We go all the way to Schlem's canal to dissect trapezoidal membrane. And here, this is the new part of surgery. You create a pocket and an opening into the suprachoroidal space. We inject a viscoelastic device to create that pocket. As you see, the implant is rather bulky, so this was the first case. But despite that, putting it inside did not turn out to be such a big, difficult surgical challenge. So it's inside, and now you just need to slide it in, and if it stays in that pocket, no suture needed. And then just close the superficial flap, put our regular sutures, and close the conjunctiva. So the multi-center study is underway in 24 eyes, 5 centers, all practicing non-penetrating glaucoma surgery. This was the patient you saw the video on the first post-operative day, no side yard, nothing unusual. Here you see swept photos of the images with the anterior device, and you can recognize the rectangular device in the suprachoroidal space, and you see how the trapezoidal membrane is visible here dissected. This is the first patient, happy, and you see he goes home and he already obtains the first measurements at home with his device. These are comparisons in all 24 patients so far that have been operated. Some of them have 1 year plus follow-up, others have a minimum of 6 months follow-up. And on the x-axis, you see the Goldman values, on the y-axis, the IMate SC values. In essence, we find that according to visit, 78% to 100% of measurements with GAT and the device are within plus minus 5 millimeters mercury of each other, which is what you need for regular approval of the device. Is it safe? Well, that's the main question that I kept for the end. Well, after 1 year, there was no serious adverse event. We were interested whether having such a bulky device in the suprachoroidal space would create choroidal detachment or even retinal detachment. We had one case of choroidal detachment, which fortunately resolved under regular medical treatment. And there were no other adverse events different from what happens after non-penetrating glaucoma surgery. In conclusion, we now have, thanks to at least 2 devices for which clinical trials are available, regulatory approval are present, access to improved management by having more IOP data available. We believe that having sustained release treatment in the future will also require some kind of continuous IOP monitoring if you don't see the patient as often in the clinic, because he comes for eye injection every 6 months, then it's important to make sure that these sustained release devices work for the duration of the time you expect them to work. Having access to home monitoring is important. We see that having access to the information also gives patient better confidence and better adherence with the medications, improves quality of life. Big challenges, of course, remain. Are these devices safe over the mid to the long term? We only have 1 year data available for the newer generation. Interpreting so much data will now go beyond the simple clinician's abilities and time. So here is where machine learning comes into play. And obtaining all this information will probably challenge us to reevaluate the way we practice glaucoma. And getting reimbursement, of course, is important, but should not be a major challenge if we can see the clear clinical benefit of these technologies. Thank you.
Thank you very much, Kawe. This was a great talk, and you certainly have experience with this. Hector, you want to ask a question to Kawe?
Yes. First of all, thank you for this presentation. It was very interesting. We don't have any of these devices here, and I would ask, during the last years, we have assisted to the presentation of many tests or techniques that are trying to resemble the diurnal curve of IOP, like water drinking test or ivapamine test or others. Do you use that in your daily practice, or what importance you give for this test there?
Any test that allows us to get more IOP data is of benefit. And for the water drinking test, for example, which you mentioned, we have a good body of data that shows us that it's of use, that the peaks you detect during the water drinking test reflect reasonably well what patients have if they stay overnight and obtain a full 24-hour measurement. And these are tests, for example, water drinking tests, which we also perform in our center. Whenever we can, we try to do the dial attention curve. We get 6 measurements a day, which of course we still miss the nighttime values. Adding the water drinking test to that would make it more useful. You get a better reflection of how high IOP could go. And there are recent publications that also show that these peaks through the water drinking test seem to predict future progression. The other tests, all these tests are an improvement to only one measurement a day. It is the nighttime value. But probably it's just an improvement, it's a surrogate of what can happen, and the patients are more complex than we see during a single 24-hour visit, even a 24-hour visit. And we have looked at our data, and we find that when we look at those 106,000 data points, we see the high variability of IOP. We have published that just recently in ophthalmology. We see that having one 24-hour period measurement reflects a bit what happens in the coming 2 to 3 months, short term, but is a very insufficient predictor of what happens at 1 year or beyond.
That's great. That's great. Thank you so much, and thanks a lot for that great talk. Thanks.
Thank you. It was my pleasure.
Kawe, this was a great talk, and you have shown that many patients have their IOP peak around in the early morning before we certainly wake up, and some may think that this is necessarily pathologic, which may not be the case. It was shown that this also happens in normal patients, and in fact, the pressure in the cerebrospinal fluid also goes up during the night when we are in the supine position. So this may be also a physiological situation in which both pressures rise, and the effect in the lamina cribosa remains the same. Of course, this is just speculation, but I want your thoughts on this. If sometimes we listen that these peaks that occur before we wake up are pathologic and sometimes may change the conduct with a certain patient, which I think is not correct.
I couldn't agree more, Fabian. One important piece of data we miss are studies, long-term studies that look at progression or development of glaucoma and that look at 24-hour IOP behavior. There is not a single one. So yes, we do not know the importance of the nighttime IOP behavior typically rise. We know that IOP affects long-term behavior, but all the studies have looked at daytime IOP. So this is an important piece of information we miss. And now that we are having slowly access to long-term IOP monitoring, these studies could be envisaged and hopefully conducted. We have looked at the effect of different medication groups. This is not published yet. And we see that some medications have clearly a nighttime effect while others do not. With the knowledge we are gathering, one thing I would advise against, and this has been shown in the sleep laboratory in San Diego, and here we see it with the continuous IOP measurement methods, is that beta blockers have really very little effect at nighttime. And we have looked at that in our cohort of 22 patients over several years. Very little effect or no effect. At the same time, they may, and they will probably lower perfusion pressure through their systemic effect. And then this could increase the gradient between IOP going up at night, but blood pressure going down, enhanced by beta blockers. So these are things that we can already consider in our clinical management. But hopefully, for the 105th anniversary of the Argentine Society, or 110th, we will have access now to long-term studies looking at progression and having 24 IOP and continuous IOP measurements available. And then we could answer this question better.
Yeah, I was going to say that we really need something that could be used on a daily basis without having to do surgery in a patient. Of course, having something implanted in the eye may even get more accurate values that what we get through the cornea because it eliminates the cornea factor. But of course, this is interventional, and not every patient goes to surgery in glaucoma. So we look forward to something that we could use in the clinic. In fact, you know, I used the triggerfish when it was launched, and I was impressed. It's very, you know, it's a pity that we cannot measure in millimeters of mercury, and at least we can see differences as was shown in many publications, many of them by you. So so we look forward to seeing new advances in the next few years, and why not in 5 or 10 years get more data. Thank you very much, Kawe, for your availability and your talk and your experience. Thank you.
Thank you, and stay safe.
Thank you so much.
Hola, yo soy Joel Schumann y vamos a hablar de OCT en glaucoma. Ahora yo voy a hablar inglés. So we're going to talk about what is new in OCT for glaucoma, and these are my disclosures. The nerve fiber layer can show abnormalities in glaucoma before those abnormalities are detectable with visual field. So when the nerve fiber layer is thick, the average nerve fiber layer thickness is greater than 75 microns, let's say, it's unlikely that you'll see a visual field defect even if there is an abnormality in the nerve fiber layer. Whereas once the nerve fiber layer declines to 75 microns or less, it's more likely that there will be a visual field defect that corresponds with that average nerve fiber layer abnormality. Until you get to about 55 microns mean nerve fiber layer thickness, at which point there's a floor effect below which the nerve fiber layer doesn't fall. And these numbers are for Cirrus OCT. Other OCTs have similar effects, although the numbers may be slightly different, slightly lower, for instance, on the Heidelberg spectralis. below that floor effect on OCT, you can still measure changes in the visual field. So don't be fooled into thinking that the patient is stable, even though the nerve fiber layer or the average nerve fiber layer is unchanging. They may still be getting worse, and that should be followed with the visual field. You also may be able to see local changes in the retinal nerve fiber layer thickness if you have a volumetric OCT, so 3D OCT, like what you would see with Cirrus or Taucan or OptiView. So this is a schematic that just illustrates the points that I just made. When the mean nerve fiber layer is thick, the abnormalities are primarily detectable in structure. Occasionally you'll have a visual field defect, but that's uncommon until you hit the tipping point at about 75 microns on Cirrus, and then you'll find that there's good relationship between structure and function until you get to that floor effect at about 55 microns, and then you will be able to measure functional change on the visual field. The global measure will be more or less stable due to that floor effect on the OCT, but you may be able to measure local changes on the OCT. And initially we found this in cross-sectional studies, and then later showed the same effects in longitudinal studies. Now, when you're looking for change, the Cirrus has the most robust, most mature change analysis program called the Guided Progression Analysis. And what I look at first is the heat map. These two on the left are the baselines, and then the subsequent exams are compared to those baselines. So this is an event analysis. The orange shows where the retinal nerve fiber layer is statistically significantly thinner than the two baselines, and the red for the first time, and then the red shows where that's confirmed in the next subsequent scan. So these are showing you where you have statistically significant thinning of the nerve fiber layer, and you can see that in the next scan here that red area is larger. And when the abnormalities, the statistically significant thinning of the nerve fiber layer is in a location and a shape that is consistent with glaucoma, you can be fairly certain that this in fact is glaucomatous progression. And then these values, which you can see better here on the right, are taken from the circumpapillary area. This is extracted from the volumetric scan. And you can see that there's a statistically significant thinning of the nerve fiber layer, and that's a trend analysis. So this is the average, the superior quadrant, inferior quadrant, and you have the rate of change listed here. And then when the cup to disc is increasing, and you can see this statistically significant increase, and you have thinning of the nerve fiber layer, you have confirmation that in fact the change that you're seeing is real. And here in the RNFL thickness profile, you can see the area that's becoming thinner. These solid black line and dashed black line are the baselines, and then the blue line is today's exam. And you can see this statistically significant thinning inferiorly. The data can also be presented in a tabular form, as you see here. In the advanced glaucoma imaging study, we found that 84% of people who developed visual field abnormalities who had either preparametric glaucoma or were glaucoma suspects, 82% of those visual field conversions were preceded by an abnormal OCT, and it was about 2 years between the time of the abnormal OCT and the visual field conversion. If we're looking at progression, what we found was that in glaucoma suspects and preparametric glaucoma, there was about a 2-year lag between the appearance of the abnormal OCT and the appearance of an abnormality on the visual field. And in people who had manifest glaucoma, parametric glaucoma, we found that there was about a 1-year lag between the progression event on the OCT and the progression event on the visual field. So to summarize those findings, both the nerve fiber layer and macular OCT outperform the visual field in detecting abnormalities and progression early in glaucoma. In moderate and advanced glaucoma, the retinal nerve fiber layer progression rate decreases due to the floor effect, and local measures may continue to detect progression well into moderate to advanced glaucoma. It's important to use both the retinal nerve fiber layer and the macular OCT in addition to the visual field in the assessment of glaucoma and its progression. Let's turn now to artificial intelligence. And the first artificial intelligence technology that was approved for medicine was in ophthalmology. This is approved by the U.S. Food and Drug Administration, and that is the device to detect diabetic retinopathy. And this paper shows very high AUC for the validation of that deep learning algorithm for detecting diabetic retinopathy in retinal fundus photographs. There was a paper that came out fairly recently, this is in 2018, that showed what you could extract from retinal fundus photographs in addition to simply the information about the fundus. And one of those things was quite surprising, which was gender. The area under the receiver operating characteristic curve was 0.97, which is amazing because humans are not able to do this. We're not able to tell whether the gender is male or female, and yet the AI was able to make that discrimination. There are other types of discriminations the AI was able to make, including cardiovascular disease, et cetera. We and others have looked at AI for glaucoma using OCT. In this paper, we used a feature agnostic approach for the detection of glaucoma, and what we found was that using that feature agnostic approach, in other words, we didn't say we're looking at the nerve fiber layer or we're looking at the macula, we just provided the volumetric scans of the optic nerve head or macula and let the computer decide whether those scans showed glaucoma or not. So using this feature agnostic approach compared to the typical parameters that we might use like nerve fiber layer or GCIPL, we found that the feature agnostic approach did much better. And so here you see an AUC of 0.94 using deep learning versus 0.89 with the best machine parameter using standard parameters. And this is the class activation map, which is showing you where the machine was looking, where it thought that there was high value with regard to the diagnosis. And you can see that in glaucoma, in the area of the nerve fiber layer, and here in either side of the optic nerve head, and in healthy eyes, the cup to disc and what looks like the lamina. So the deep learning outperformed the various conventional methods. Although no prior knowledge was applied, the class activation map showed relevant structures for glaucoma diagnosis, and the agnostic data-driven approach seemed to work and appears to be potentially powerful. We also looked at whether or not we could predict what the visual field tests would show from the OCT volumes looking at deep learning. And here we had 1029 subjects, both healthy and glaucoma, 3651 pairs of OCT volumetric scans, cubes, and 80% of the data were used for training and 20% for testing, which is quite typical. And what we found was that we could predict the VFI with a good AUC as compared to standard methods. And so this deep learning approach appears to be able to take the structural information from the OCT and make a good prediction of what the global visual field parameters will be. So using these raw data, the deep learning achieved an estimation error within about 2%, whereas using conventional OCT biomarkers like the nerve fiber layer or the GCIPL, the best estimation error was about 5%. Finally, in terms of forecasting the nerve fiber layer thickness from prior OCT data, we looked at how 3 prior visits would predict the 4th visit, and this was trained on a longitudinal data set using 869 healthy suspect and glaucomatous subjects, and the forecasting of the performance was tested on 230 separate subjects. And so we input information about age, gender, intraocular pressure, conventional biomarkers, and there was the raw OCT image data, and using these data, what we found was that deep learning did better than the conventional method, which is GPA, in predicting the future OCT. So the deep learning outperformed the conventional regression methods significantly in all subgroups, and the disease status did not affect the performance. it appears that the knowledge-based approach, looking at what we think is important, the neurofibrillary, the GCIPL, is outperformed by the agnostic data-driven approach, and that there appears to be untapped information in the raw OCT data, and we're just beginning to understand where to look. An agnostic data-driven approach may uncover new insights in glaucoma biomarkers and pathogenesis, and may improve clinical patient care going forward. I want to acknowledge our collaborators at IBM. This is the IBM Watson research team in Australia, with whom we've done the deep learning investigations. This is the Advanced Imaging for Glaucoma group, led by David Huang, who was the PI of this study. And this is our group in New York at NYU, and I appreciate the opportunity of working with these people. Again, our collaborators, and I want to thank you very much for your time and attention. Thank you.
Thank you, Ike, for accepting our invitation. And the next speaker is Ike Ahmed. Ike is Assistant Professor of Ophthalmology at the Department of Ophthalmology at the University of Toronto, and also a clinical professor at the University of Utah. He's a well-known leader and innovator in anterior segment and glaucoma surgery. Ike, thank you very much for joining us in celebrating the first 100 years of the Argentinian Society of Ophthalmology. And you're gonna teach us what is new in glaucoma surgery. Thank you very much.
Well, Fabian and Hector, thank you very much for the very kind invitation. I hope you can hear me okay. I'll just bring my mic closer here. Thank you so much. It's an honor. I have such fond memories of my times visiting Argentina, and during these difficult times, it's obviously hard to see people. So it's an honor to be here. Congratulations on 100 years for the Argentinian Society of Ophthalmology. And I'm pleased to speak as part of the Argentinian Glaucoma Society symposium and session here. So thank you very much. It's an honor. It's been 100 years for the society, which is great. The other distinction, unfortunately, it's been 100 years since the last pandemic. So there's something to celebrate and some things not to be so happy about. But I think we're all coming out of the pandemic and learning from it. And these are opportunities for us to really share more than we ever have. So thank you very much. I'm just going to share my screen. What I'm hoping to do is talk a bit about some of the new surgical approaches in glaucoma, how this has perhaps changed our algorithm. And I don't have all the time to go through specific techniques, but I want to speak more about the premise and the approach, as we have these approaches and techniques that have now been around for some time. I do have a lot of disclosures to mention here, which includes many companies that I work with in this space, which serve as a conflict of interest reminder. I also have a disclosure that I have a strong dislike against red eyes and irritated eyes from glaucoma drops. Well, let's remember again, with all glaucoma interventions and approaches, medical, laser, surgical, otherwise, it's about quality of life, not only from the disease, but also from the treatment we give to patients. And sometimes the treatment we give to the patients themselves creates quality of life issues. So our goal really is to try to address these issues. It's not about IOP or medication specifically, or even visual fields. It's about quality of life. And we have to remind ourselves of this all the time in terms of how we choose one procedure or the other. We know, of course, that topical glaucoma therapy has a number of different advantages, which is fantastic, the safety, but also has significant quality of life issues in terms of periocular structures, as well as red eye and irritated symptoms as well that exists. There are numerous studies that have looked at quality of life, and we know a variety of different symptomatic issues and vision quality of life issues with regards to topical therapy that impact patient satisfaction, we know as well. Compliance remains to be a problem and a challenge, and we've seen now the relationship between compliance and poor adherence and progression. This is recently shown in the SIGIS study, looking at the relationship between missing glaucoma drops and visual field progression, showing a correlation. And so this is an important aspect to think about. And of course, the SIGIS trial showed at least patients who have more moderate disease have better visual field stability over time. And maybe this is related to IOP as well as fluctuation, as well as compliance. And so when it comes to surgical approaches, really the two groups we're trying to address are patients who have mild to moderate disease that aren't the best served with our current therapies, and also patients who are more classic in the sense that they are exhausted the maximum tolerated medical therapy and they're progressing and they need to have a major surgery. It's important I mention this because often we get confused in terms of where does surgery fit? Where do new surgical procedures fit? And they don't all fit in the advanced patient who needs to have major surgery. And it's a bit erroneous to compare one and the other. Interventional glaucoma, which I think is sort of a movement that has been started and moving in this direction, is dealing with patients earlier, doing it lower and safer, and addressing adherence as well. And this is sort of the premise of MIGS in some ways in terms of why we try to achieve these outcomes, really predicated on safety. Efficacy has been something we still are working on and I think are lacking in some ways, but safety and quality of life has been important. So how do we approach these things with a surgical algorithm? Well, the first point is the surgical mindset and understanding the ability for us to use our hands to do the work and know the skill set more than ever makes a difference with the outcome. This is true for any surgery, but particularly for some of the more technical procedures. When it comes to surgical approaches, we have a variety of options available within MIGS or BLEBs or cycloablation. I've grayed out suprachoroidal because this is an area that still has not yet come to fore because, of course, issues we've had with some of the issues and devices in this space. But you can see a lot of options exist for our patients. And this is a AGS position paper published in Ophthalmology Glaucoma recently, which just shows how we can divide up surgical procedures as MIGS and traditional surgery. Within MIGS, we have bleb procedures and non-bleb procedures. And we have non-bleb procedures that are either excisional or implants, and we have ab internal and ab external bleb performing procedures. So it's quite a busy slide, which kind of just shows all the different approaches, whether they're implant or not, cutting or not, and whether they're bleb procedures or rather internal filtration. And this is where we try to address some of these issues in terms of patients who have medication issues or patients who need to have very low pressures. And we have ways to look at these. And the best way I like to look at them is where the aqueous outflow is diverted or enhanced, whether it's Schemm's canal or supraciliary or subconjunctival. The first most important thing in terms of surgical approaches is my patient controlled? That's usually what we try to really focus on first. And this usually means is the peak pressure below target or at target? Has the visual fields and OCT been stabilized? Is the patient adherent and other tolerating therapies? When patients are not controlled because of any of those issues, the question is what next? Is it more meds? Is it SLT laser? Is it bleb surgery? Is it trabecular meshwork mixed procedures? These are all questions. The first and foremost question is to bleb or not to bleb. That really is honestly the question I always ask myself when I see a patient in my examination lane and they're here for a glaucoma assessment or follow-up. Certainly if the patient needs a pressure at 12 or lower, this is where we have to go to the bleb. And we have a variety of approaches now with subconjunctival surgery, both older methods like trabeculectomy and tube shunts, as well as some of the newer methods which include microshunting and microstenting. We know traditional surgery is powerful. This is no question, the power of traditional filtering surgery as shown in many studies. We also know that traditional filtering surgery, however, also has a number of potential complications, although these complications have become less over the years with better surgical technique and patient selection. This is certainly the most powerful procedure, best for lowest pressure, but it is fairly intense, long postoperative course. The patient has anatomical and refractive changes that may occur, and there are some serious short and long-term considerations as well with these procedures. We have subconjunctival mixed procedures like microshunting and stenting, which have a more standardized approach, less invasive in the sense of the dissection involved and the control that we get with these procedures, may reduce some of the postoperative intensity and recovery and anatomical and refractive stability. The question is, are these effective? And studies have shown some of them are not as effective or similar, but by and large, we still feel trabeculectomy is the most effective procedure so far as of yet. We have, again, different approaches, both the Zen implant, which is a typically delivered ab internal, versus the PreserFlow implant, which is ab external. Both of these, again, control aqueous flow into a bleb posteriorly with better morphology, but do require mitomycin, of course, importantly, to control wound healing. And this, however, is done in a safer way, we believe, with a more enhanced recovery, better blood morphology, and pressures that get close, but not necessarily as good as trabeculectomy, and sometimes requires some needling. We have to remember, though, that bleb, we do differentiate between different patients and procedures. And it's not just about IOP and medication. It's about, again, quality of life, visual recovery, refractive stability, frequency of visits, the morphology, and long-term success for these blebs as well. Now, for the patient that may require pressures that may be more modest, maybe more mid-teens on less medication, this is where we look at trabecular conventional outflow, which we know, of course, physiologically can lower pressure down typically in the low to mid-teens if done in a patient who otherwise has normal outflow pathway beyond the canal. The anatomy is very intricate in terms of how we do the procedures, and every collector channel is different in terms of its capacity. Some are larger, some are smaller in terms of where the aqueous will flow. Now, we have a variety of options in the trabecular meshwork space, in the canal space. We have implants, we have dilation procedures, we have cutting procedures. We have some procedures that are somewhat more expensive, other procedures that can be done with a suture and a knife and a microforceps in a less expensive way. And so every surgeon and every patient around the world does have access to MIGS. And this is all the options that are available to us. And I think we are still figuring out where the differences may lie between the different procedures. It's important to know, of course, that they all work on the same pathway here, and they can be considered, again, stenting or dilating or cutting. And these are some of the ways we look at them as well. We must remember, all these procedures work by overcoming the obstruction and bypassing the level of the TM. They do make an assumption, however, that the rest of the outflow system is intact, that the episcleral venous system is intact, and the venous plexus is intact, and the collector system is intact. And this isn't always the case, which may lead to differential success rates. This is a nice example of a neoprene cast model showing that we are bypassing the TM, but we have still a ways to go for aqueous, and we need to determine the best place to do these procedures and the best success rate. So these are very safe in our experience. They are physiologic. They control this hypotony prevention. And this also leads to the lack of efficacy because of episcleral venous resistance and other resistance that we don't necessarily perceive. And this has been the challenge for trabecular meshwork: is, are they effective enough for our patients? Suprachoroidal outflow, of course, may overcome this issue because of the larger space we can drain into and a different mechanism of action. But can they balance safety and efficacy? Because we do know that hypotony can occur. We do know that wound healing is more of an issue here with scarring in the supraciliary space. But the advantages may be no bleb, but with lower pressure, and we still have to be concerned about at least what we saw with SiPass in terms of the placement of these devices. And so this is still something to be continued, I would say. We also consider where glaucoma surgery is done, whether it's with combination cataract surgery or standalone procedures as we do on their own. So we have an issue around safety and efficacy. How do we decide a procedure? Some procedures we have more efficacy and lose safety. Others we have a higher safety, but we lose efficacy. And this is the tug of war we see right now in 2020. Trabecular meshwork safety versus subconjunctival efficacy. And can we find the right patient profile? Some of this will be based on what the target pressure is. The lower we need to go, the more we need to go traditional or bleb surgery. However, many patients don't require this. This graph just shows IOP lowering on the y-axis and risk level on the x-axis. Medications and lasers, very safe, but not as effective. And trabeculectomy, very effective, but has some safety concerns. We ideally would like to be where the red star is. Very safe, but very effective. We don't have that procedure yet. You can see where I put trabecular meshwork as subconj MIGS. We're kind of in the middle here. And I think this gives us one more option that we need to look at patient selection. So how do we decide what patients? This is my algorithm. You can see it's a bit choppy and a little bit complicated. And let me just go through it for you. Procedure attributes, basically, we think about safety, efficacy, postoperative management, ease of use, visual recovery, and cost of reimbursement. These are all drivers to choose what do I use in my own hands, as well as what I can do the best as a surgeon. Some of the variables are whether I'm combining with cataract or not, how old is the patient, the target pressure, whether they're controlled, and what the severity of disease are. These are some of the variables we plug into the algorithm. We can think about 4 distinct patient populations as I finish my talk: combination cataract, standalone patient without cataract surgery that needs a target in the mid-teens, standalone pressure around 12, or standalone we need low pressures in single digits. Let's look at the combination cataract. These patients, I want to avoid a cataract and a bleb. Cataract surgery and bleb surgery together does lead to more bleb dysfunction and failure. And I think it is better in terms of success separating them out if we can. We want to do whatever is safe because we want the least impact to our cataract patients in the recovery. Cataract surgery is a great procedure with a great recovery. We want to avoid altering that recovery and that result. And choose a procedure that has good synergy where they can work together, not antagonistically like bleb surgery and cataract surgery. This is where I think Sem's canal stenting can work well with its high safety profile, reduction of hyphema risk, and smooth postoperative recovery. However, efficacy may not be fully there. When we're doing standalone procedures and we want to get into the mid-teens, these patients are not so bad. We don't want to do a bleb on them. We want to reserve the bleb till we need it. But we want to have a good probability of getting low enough amongst all the mixed procedures. This is where we want to enhance aqueous outflow. And this is where I think admin-turner trabeculotomy, whether it's suture GAT or a cutting procedure, I think has a role in these patients. We're going in specifically for the sole reason to lower pressure modestly. What about patients who need pressures of 12? Well, these patients, we know that these patients, we have to get low enough and a bleb is required for control. Trabecular meshwork is not going to do it for most of these patients. We want something perhaps is more predictable, less invasive, and faster recovery than traditional surgery. And we want something that's going to have better bleb morphology. This is where subconjunctival MIGS may have a role as an alternative to other bleb surgeries. And finally, when it comes to standalone procedures that need low pressure, we want the lowest possible pressure. We need to titrate lower by suture lysis and needle if needed. And we have to take the risk to get there. And this is where trabeculectomy, I think, has, of course, an important role and remains in our practice as importantly. So a lot of things to consider in the overall glaucoma practice. Where does SLT fit in? First line more. How do we escalate with power? We do the stepwise therapy based on target pressure and tolerability and control and progression. I think MIGS works well when combining, and whether the value is there or not, I think is a good debate in terms of cost effectiveness. Standalone procedures, I think, have a role as an alternative to bleb procedures. And subcons MIGS surgeries, I think, again, are something we can do perhaps for patients that don't require a very low pressure. Well, what's next for glaucoma surgery? We want to try to continue to improve to maximize efficacy while retaining safety and control. This means better visualization systems, improving delivery systems. We have to address wound healing. This is, no matter what surgery we choose, wound healing will cause long-term failure. This is where drug elution with IOP lowering or wound healing modulation is upon us. Be able to have feedback mechanisms with IOP sensors is the future vista as well. And using imaging to help us to determine the right patient for the right procedure and where to place these procedures are important as well. And using additional outflow pathways as viable targets, including supraciliary space. And also ocular surface is also an area that's being explored and looked at as well. So thank you again, Hector and Fabian, for the invitation to speak at the 100th anniversary of the Argentinian Society of Ophthalmology, a very rich history, no doubt, in ophthalmology and glaucoma as well. So gracias, thank you.
Thank you very much, Ike. Hector, do you want to ask Ike something? We have Ike with us, so that's great.
Yes, I have many questions, and again, thank you so much for sharing your experience with this. And if you have to perform a combined surgery, I said a cataract surgery plus MIGS. What do you prefer to do first, the lens extraction or the MIGS surgery? Because I have read many, it's so simple, the question, but some teachers prefer to extract the lens first and then perform the glaucoma surgery. I said in the same procedure. What's your experience with that?
Yeah, I mean, for me, there's no question that the best view, the eye being firm, and the less chance of having too much blood reflux is to do it before the lens extraction. The only exception would be maybe somebody who has a very shallow chamber, which is rare to do MIGS for. Usually we do lens extraction only.
Yeah.
And those patients, we can understand maybe doing it after, but the angle opens up with viscoelastic beautifully for open angle glaucoma. There's really no reason to open the angle up by taking the lens out first, number one. Number two, blood reflux is sometimes an issue during the surgery because now we've opened up the canal, especially if we use a cutting approach, like a suture. And for these patients, we have to make sure we maintain pressurization in the anterior chamber between instrument removal and keeping a viscoelastic in the eye. So that is one annoyance with doing it earlier sometimes for some of these cases. But otherwise, I want to like to have the best view, the best placement. And sometimes the eye is very soft. After lens removal, the cornea has a bit of edema. The view isn't that great. You got to put so much viscoelastic in the anterior chamber to get the eye firm. And the view is just not great. And too much blood reflex now because the canal is filled with blood. So for me, it's 100% actually, to be honest with you. I feel very strongly this is the best approach. Some people are worried about maybe damaging the capsule. Well, do the capsulorhexis then. Yeah. And then do the MIGS, and then go back and do your phaco if you're worried about visualization during the capsulorhexis. But once you irrigate in the eye, any blood that's there will be aspirated.
Perfect. That's great.
Definitively, we do have a wide menu of options for glaucoma surgery now, which is great. In the past, we had a very few options, and now the menu is really very, very wide. And so we're working towards more individualized glaucoma surgery, and I agree, and I think this is a work in progress. We have advanced a lot, but there's still a lot to do, and that is very exciting. This is a very exciting moment to be in glaucoma surgery. And my question is, do you combine different mixed procedures and in the semi, and why and how?
Yeah, it's a great question, Fabian, and it is very exciting to be in this field and be here in the middle of all of this as we all are. It's also very frustrating, as you know, because every time we have excitement for 6 months, then we say, oh my God, now we fail at 1 year, and this is glaucoma for a lifetime. And so as much as I'm excited, I'm also frustrated in many ways. This is why I've not been able to shave or cut my hair and I get more white hair, which is all of us in glaucoma. So that being said, we have a fight, we have a mission, we have to continue that. So the idea of combining MIGS is interesting. I think it may have some merit. However, in my experience, I haven't found it yet to be something that adds a lot of value. Now, of course, bleb surgery, in my opinion, there's no reason to combine MIGS with bleb surgery. I think that's just going to ask for more problems because bleb surgery will be predominant outflow mechanism. The pressure is going to be low, and you're going to get blood reflux in the anterior chamber when you do a trabecular procedure. Combining a trabecular procedure, for example, with cycloablation is interesting. We have done this with, for example, with micropulse, with ECP, endocyclic photocoagulation, to address inflow and outflow. I think that the results, I think, may be a little bit better, but as we all know, to get enough of an effect with cycloablation, we have to do a pretty strong effect. A light therapy doesn't give us a lot of impact, and so we have two procedures which are I think synergistic in different ways, and we have not yet found really a big difference in that outcome. So to summarize, and we also done suprachoroidal and trabecular meshwork, and I think for different reasons, I just haven't found that they really provides a real definitive improvement. Generally speaking, aqueous wants to travel where it wants to go based on the least resistance, and that will become the primary mechanism. And either maybe one procedure isn't effective enough or they don't combine together. I do hope we will continue to learn from this. I just haven't found that success yet with combining these procedures. Others are looking at this as well. And that's been my own anecdotal experience so far, Fabian, in our early experience with this.
Okay. Thank you very much. I thank you for participating in our special glaucoma symposium celebrating the 100 years of the Argentinian Society of Ophthalmology. And we look forward to meeting you again soon, either virtually or hopefully physically. Okay.
Thank you very much. Keep up the great work that you're doing as well, Fabian, and everybody in Argentina. And everybody stay safe and well. Thank you. Good luck. Congratulations.
Thank you. Thank you very much.
Thank you so much. Thank you.
Thank you, Jeffrey Lippman, for being with us. We're going to begin. I'm going to introduce you. Dr. Jeffrey Lippman is the Yearly and Bernard Brown Professor of Ophthalmology, Director of the Glaucoma Service, and Vice Chairman of the Department of Ophthalmology at Columbia University Medical Center in New York. He's the Editor-in-Chief of the Journal of Glaucoma, and he has also been President of the World Glaucoma Association. He's gonna talk to us today about the impact of COVID-19 on glaucoma care. Thank you, Jeff, for joining us in celebrating the first 100 years of the Argentinian Society of Ophthalmology.
Well, thank you very much for the invitation to participate in this great symposium. It is an amazing milestone for your society, ophthalmology and medicine in Argentina. So again, congratulations. You know, we live in a very interesting world at the moment. Of course, COVID-19 is affecting all of us, but we also live at a time when we have amazing technologies that allow us to quickly advance our field, take better care of our patients. And the rest of the symposium will deal with that, of course. But I'd like to speak about COVID-19 and how the coronavirus affects how we interact with our patients, how our patients feel about glaucoma care, and what we can do to improve glaucoma care under these circumstances. Here are my conflicts, but none of them really apply to this talk. This is a slide that I borrowed from Dr. Jack Chaffee, who's the chair of ophthalmology at Columbia University. And he created this slide as we began the various phases of our exposure to the coronavirus. And there was that pre-COVID period of time in December, January, February of this year, where we were practicing and the virus was in the background. And then in March, we began to have a very rapid uptick in coronavirus cases in New York City. And as you know, it became the epicenter of disease in New York. We had a very feared peak, of course, but that was actually suppressed. And we actually recovered from that nicely to this point in time when we have the lowest rate of virus load in the country, in the population, the United States at least. And as those infections waned, of course, we do expect some reemergence later on. Our practices initially collapsed completely and then gradually came back. And this has been the experience worldwide. And as our experience, as the patients return to practice, we begin to get back to some more normality, but things, of course, are not normal. We know that patients need to be separated in the office and so on. So things are very far from the way they used to be. And our practices continue to slowly build. Of course, across the United States and across the world, there are these various phases of disease. The peak in phase 1 and in the early recovery period of phase 2 and phase 2B, where we are now. These are different prevalences of disease across the world, and we each enter them in different phases. But if we eventually seek to go back to the old status quo of seeing patients, we are going to fail. And that failure is because of a wide variety of issues. I'll cut to those in a moment. So how are we going to recover? You know, what are the guiding principles of taking care of patients, glaucoma patients, during this period? And then we have several guiding principles. For those of us who are involved in all aspects of ophthalmology, we need to continue the clinical teaching and research missions of our departments and our lives, whether we're involved in professional societies like this one, teaching residents or researchers. We need to maintain the highest level of expert care and surgery for our patients during this difficult time. We need to remember that the teaching mission that we're all committed to for our medical students, our resident trainees. Here are some of our graduating medical students who are going into ophthalmology, posing for a picture. and our researchers, all are affected by this process. Secondly, we need to maintain, obviously, a very safe environment for our patients, our staff, and ourselves. And that's not very easy to do in this process. Early on, of course, we didn't fully understand the implications of the easy transmissibility of the disease. And I think now with safeguards in the office, we're much better at containing the virus in physicians' offices. And some of these things I think we're all familiar with: maintaining strict patient screening and sterilization protocols. We've all sought to minimize in-person visits, by perhaps using telemedicine for some visits, or condensing glaucoma visits. Instead of a glaucoma patient coming in 2, 3, or 4 times a year, perhaps they only need to be seen once a year or twice a year. And that has implications for how the amount of testing that's done at each visit, and also implications for how we handle these patients when they're in the office. Because we can't see patients in such a dense fashion, we're expected to see patients during extended hours, perhaps weekend hours, and develop new clinical templates. Of course, that involves many aspects that are now fairly well known to us: maintaining social distancing. We have to have a greeter or a navigator when the patient arrives in the office to do screening. When we have that initial examination, as I mentioned, often that follow-up visit could perhaps be via telehealth or an asynchronous hybrid visit where the testing is done at a different time or at a different location, and then we review the testing data later on. And there are a whole series of sequelae to these actions, including redeployment of staff, reconfiguration of the space in our offices. And that's particularly difficult during a time when the finances of medicine are very difficult. It's hard to reconfigure spaces to account for the new pattern of patient flow in the office, for example. We, of course, can't have waiting rooms and clusters of individuals. So I think we need to be innovative. And fortunately, ophthalmologists are among the most innovative people in medicine. And we need to rethink our clinical care models and explore new opportunities. So one of those things we can do is to shorten the visit time. We need to eliminate some of the unnecessary testing we do, and I'm going to come back to that in just a few minutes. And perhaps initiate some form of home testing. Perhaps we can develop better visual field paradigms, for example, that patients can do at home. There are, of course, very specific issues for glaucoma care. How do we measure intraocular pressure? Do we use a Goldmann tonometer and have to sterilize that between patient visits? Do we use disposable tips or other types of tonometers, like a rebound tonometer, for example, or a tono pen? Each of these devices has its own set of problems in terms of the accuracy of the measurements and how it compares to the reference standard Goldmann type of tonometry we're all familiar with. And that in turn has implications for decision making. I find it rather difficult to often make decisions about intraocular pressure control when a serious decision needs to be made if I'm not using the Goldmann tonometer. The same thing's true for perimetry. It's difficult to make a surgical decision, let's say for trabeculectomy, if we don't have a recent field for decision-making and for comparison purposes. And that's challenging in terms of the difficulty that we see with perimetry in terms of sterilization. So for perimetry in particular, should we switch our paradigm and perhaps do less perimetry, try to avoid the perimeter bowl for patients when COVID is in the air, and perhaps do more OCT imaging. Gonioscopy, for example, perhaps that should be replaced by anterior segment OCT, a no-touch technique. I rarely did anterior segment OCT in clinical practice before we were dealing with the current COVID emergency, but I do find that I'm doing it more often now just to avoid the need to sterilize gonioprisms. So what about perimetry? And I asked this question, are we using our technology for our patients, to our patients and our best advantage? I think there's been a gradual trend towards heavier use of OCT imaging for glaucoma and perhaps a little bit less use of perimetry. But I think that this is an opportunity for us to use our technology better and develop better paradigms. And we should not waste the opportunity that COVID provides us to change our paradigms rather rapidly, perhaps more rapidly than we would have done without the disease present. And I'd like to focus on just one small aspect of glaucoma care, which is fairly common for us, the glaucoma suspect or the ocular hypertensive patient, for a moment, and just show you an example of a patient who comes in perhaps with early glaucoma in the right eye, who has inferior loss. And the patient's followed for many years. I think it's probably about 10 years for this patient. And the field is completely unchanged during that time. And the patient has a series of visual fields that are unchanged. Now, of course, we're getting these visual fields to make sure the patient's not progressing. But in hindsight, perhaps we didn't need quite so many visual fields to determine that this patient was stable. And here's OCT imaging for this individual. You're familiar with this as the Cirrus device with patient has perhaps some very minimal damage or neurofibrillary damage superior in the right eye, inferior in the left eye. And here's the imaging over time in both eyes. I'm sorry, in the right eye, both using retinal neurofibrillary thickness and the ganglion cell complex thickness maps. There is no change over time. Both of these patients, in both of these instances, for the retinal neurofiber layer and the macula, there has been no change over this lengthy period of time, perhaps suggesting that we could have substituted the OCT imaging for perimetry at these time points and avoided the frequent perimetry. Once we have established the status of the visual field and the status of the OCT imaging, it's relatively rare to see further visual field loss in early disease like this without seeing some kind of retinal nerve fiber layer or macular progressive damage. So perhaps in this type of patient, we can avoid extensive use of perimetry. Here's the left eye with a really essentially normal visual field. But over time, the patient begins to develop progressive damage both in the nerve fiber layer and in the macula. And even though the visual field is unchanged, it's reasonable to consider advancing the therapy, or if the patient's not on therapy, initiating therapy, just based upon the OCT imaging alone. Again, the visual field in this patient with early disease provides us with less information than the OCT imaging. And perhaps for early disease, we can cut back on perimetry. And given the difficulties with perimetry in the COVID era, reserve perimetry for those patients with more advanced disease who truly need it. Of course, all of this is based upon a field of study of structure-function relationships in glaucoma that has been ongoing for more than 50 years. This is an old citation from Dr. Spaeth describing the traditional relationship between the disc and the field, with disc changes occurring first. And the patient described to you is somewhere in this region. Of course, for all of these, for this entire period of time when the visual field remains normal, this is when OCT is very valuable and the visual field is less valuable for us. So these are the types of patients who would benefit from this more intensive focus on imaging rather than perimetry in the COVID era. In addition to changing our paradigms for care, we also need to consider about rebuilding our financial strength. I think everyone around the globe in medicine, ophthalmology in particular, really has struggled with the finances and the financial impact of COVID recovery. This is real data from our department describing our patient volume and the targets we set for this past June and for August, the end of August, this month, in terms of trying to return to some semblance of normality of 75% volume, pre-COVID volume by August 31st. We've actually reached, as of now, 90% volume, which is good. And this was just a random slide from June, just demonstrating how we began to recoup our volumes with telemedicine diminishing as the in-person visits improved. And lastly, I think we need to think about how we maintain physician and staff morale and engagement. You know, we should remember that everyone is under stress. I think everyone, all of us, feel the stress of walking around in a mask in New York City, using mass transit. A lot of people feel uncomfortable with that. People are concerned about being exposed to virus and bringing it home to their families. There are people in New York who lost multiple members of their family in a very short period of time. So we need to remember that staff and faculty and patients are all under stress, and kind of address those mental stressors as we redesign the workplace to make sure that everyone feels very comfortable. So lastly, I think that we have an opportunity. We need to, and an obligation to make lemons into lemonade. We need to continue the clinical teaching and research missions that we're all committed to. We must maintain the highest level of expert clinical care and surgery while maintaining a safe environment for everyone, including ourselves. We need to innovate. I think each one of us needs to think about our clinical care models, how we can deliver care more efficiently, and what care will look like in the future. I think this is an excellent opportunity to think about these issues in detail. We do have to focus on the finances of medicine and think about how we're going to maintain the viability of our practices and our departments. And lastly, again, let's think about everyone who we work with and make sure that they are in a safe environment, they feel safe, and they remain enthusiastic about their work. So I want to take this opportunity to thank you once again for allowing me to participate in this program. Congratulations to all of you. Thank you.
Thank you, Jeff. Thank you for sharing with us your vast experience in this. And you have shared with us many aspects that certainly are affecting all of us. My question, I have a question regarding the use of visual fields. I agree, definitively the use of OCT in glaucoma has improved a lot. And in those cases, like the ones you showed, we certainly can do less or even no visual field. My question is, what do we do with those cases that have more advanced damage?
So I think the patients who have, let's say, moderate damage first, where they have some field loss, and it's not too severe, I think those patients, we can still substitute OCT for at least some of the visual fields. I think if we're getting 2 OCTs per year and cut back on perimetry to 1 time per year, or maybe less if the patient's been stable for a long period of time, I think that can still be safe if we look very carefully at the OCTs, not just looking at the global metrics, but looking at the scan itself, making sure the scan is accurate, looking for localized change on the OCT. And then if we see something that's small or localized, perhaps asking that patient to come back for perimetry. So I think in the case of mild or moderate disease, we can begin to cut back on the use of perimetry. For the patients with advanced disease, of course, it becomes more problematic. There are some patients for whom OCT is still useful, and I think we do continue to use that. But of course, the patient with more advanced disease requires more intensive, perimetry. We're using, in our practices, which are tertiary care practices, we still have to use a lot of perimetry because we're constantly making decisions. That's where I find it difficult to manage these patients where I have to make a surgical decision. I really cannot, I don't feel comfortable making a surgical decision, particularly a trabeculectomy or tube decision, without obtaining perimetry, because the decision has ramifications for the patient and the risk is much higher. So if I'm planning a cataract surgery and I wanted to do a minimally invasive glaucoma surgery, I might not have to get a field right before that surgery if it's being driven by the cataract, the decision making. On the other hand, if I'm going to do a trabeculectomy and I'm uncertain as to whether that patient actually needs it, I'm going to have to do perimetry. That being said, in the beginning, in March, April, we did 0 perimetry. And in May, as the disease waned here in New York and the prevalence became low, we liberalized the use of perimetry. So we used to have multiple devices in the same room. We had to move them into separate locations, decrease the flow through that device. We had to create more hours for the devices to be used. And even as of this day, today, there is no great way to sterilize these devices between patients. Even though the manufacturers have described ways of cleaning the bowl, it's really not a good idea to clean the bowl frequently. Even if you spray some kind of disinfectant into it, it should be done rarely. You can't have streaking in the bowl. So it is problematic. The patients are wearing a mask.
Yeah.
Right? That's a tough thing to do in a perimetry bowl. It is not comfortable. And it may interfere with the testing. Patients become short of breath. They have to stop. They just, for all of us, I mean, we're all wearing a mask all day. It's really not pleasant. Let's face it.
Thank you. Hector?
Okay. Thank you for the presentation. Very, very clear. I really appreciate that. I have one question. Since the beginning of the COVID era, things has changed rapidly. So I want to ask you about the role of the telemedicine or teleophthalmology in your practice in the glaucoma daily practice. What's the role nowadays?
So we created, like everyone else who tried this, we created a triage system very early on. And the triage system for telemedicine, where you could speak to the patient directly, was reasonable for certain diseases. Someone had a hordeolum.
Yeah.
They could look into their cell phone and FaceTime, or we have a special system in our hospital, work nicely. For external disease, it does work. For diseases like macular, retinal disease or glaucoma, it's limited.
Yes.
When I did my first few telemedicine appointments, they wound up being social visits, reassuring the patient, having a nice conversation, good to see you. The patients really enjoyed it, but it was not efficient use of time.
Yes.
So we had a comprehensive ophthalmology team that did most of the televisits. And for really the care of a glaucoma patient who's active, a patient with field loss, it's just not sufficient. And I think we all understand that it's not sustainable. For someone who may be an ocular hypertensive who was coming in twice a year before, and now you're going to see them once a year, maybe a 6-month telemedicine visit just to make sure they're taking the drops and inquiring about side effects, that might be a useful interaction. And the patients do appreciate it. We had a lot of patients who were stuck in their, they go to Florida, when they were in New York, they go to Florida for the winter and they're stuck down there. They can't get back to New York. So we're talking to them on doing televisits with them, and they're going to see local people all around the country, wherever they are. So it's an interesting experience, but I think it's limited for patients with real pathology and for us. Our psychiatry department loves it, right? They're seeing more patients now than they ever saw. And neurology to some degree, but for what we do, procedure-based specialty with testing and surgery, high frequency throughput in the office, it's just not ideal for us. It's very hard. Right?
I agree. Thank you so much.
Thank you, Jeff. Again, thank you for for joining us in this celebration. Again, your experience with this, with the practice of glaucoma during this pandemic is very useful for us. So we want to thank you again.
It's a pleasure. Congratulations again on your meeting, and enjoy the rest of it.
Thanks.
Thanks.
Our final talk is going to be delivered by Robert Weinreb. He's the chair and distinguished professor of ophthalmology, director of the Shilley Eye Center, director of the Hamilton Glaucoma Center, and the Maurice Gage Chair in Ophthalmology at the University of California in San Diego. And he is founder and past president of the World Glaucoma Association. Bob, it is an honor and a privilege to have you join us in celebrating the first 100 years of the Argentinian Society of Ophthalmology. Thank you very much.
Well, thank you, Fabian, and congratulations to you, Javier, and all your members on the 100th anniversary of the Argentinian Society of Ophthalmology. I would be remiss with not recognizing the late Roberto Sampalese, an international giant in glaucoma. I had the privilege to know Roberto and learned about childhood glaucoma from him. I'd also like to acknowledge, as a friend and colleague, the late Alejandro Ganella, a true Renaissance man who spent time with me in La Jolla and on the tennis court. And then finally, I'd like to recognize Fabian Lerner, a great friend who I've known now for more than 2 decades. And of course, you know that Fabian is the current president of the World Glaucoma Association. Fabian, thank you for the invitation. Fabian asked me to speak about what is next for glaucoma. So what I thought I would do is talk about where we are and where we're going. Well, here's where we are today. We have providers, that's us, the ophthalmologists, regulators, companies, device manufacturers, employers, caregivers, and payers. I'd like to introduce a term that I've coined called smart glaucoma, which really is a form of personalized medicine, which will enable a clinician to develop a precise, high-definition understanding and management plan for each person in their care. Medicine today is reactive, it's population-based, and it's one-size-fits-all model of care. We're going next to personalized medicine, which is predictive, preventive, and it's patient-centric. For example, it might mean selecting the right test and the right frequency of testing for the right patient. It might mean selecting the right drug and the right dose for the right patient at the right time. And the key tools include the routine use of big data, genetic analysis, and cheaper, more powerful sensors. And it's all about big data. And big data means really big data. And some of the studies that we're doing today to better diagnose glaucoma and better detect the progression of glaucoma, we have tens of thousands of patients. In a recent collaborative study with Nili Wang at the Tongren in Beijing, we had hundreds of thousands of patients. The more data you have, the better you're going to be able to diagnose and monitor disease. Artificial intelligence and deep learning will make it possible to rapidly apply relevant medical information to patient care. We have a biobank here at University of California, San Diego, at the Shilley Eye Institute, where each of our glaucoma patients provides us with a blood sample for DNA, RNA, and other factors. We have thousands of samples collected now. What do we do with it? Well, each DNA sample provides terabytes of data. Terabytes of data, huge amounts of data. How much is that? Well, here's a large collection of books. And if you take all the texts and string out the words and count the letters in all the books, you're not even close to a terabyte. And the data that we can collect now from our patients, it's collecting from the womb to the tomb. It's in our personal cloud. It's stored and ready to separate signal from noise for treating, preventing, and also curing glaucoma. And so we'll be routinely using genetic information, which will allow us to prescribe drugs more effectively while avoiding waste in clinical time and in money caused by medications that misfire. Today in the United States, for example, we have more than 130 drugs in common use that already have an FDA label for DNA data regarding the dosage, side effects, and potential response of this. Imagine knowing in advance which of the medications will effectively treat our glaucoma patients and when to use them. And all of this leads to a new era of medicine and glaucoma care that's powered by wireless digitization. It's similar to a model already adopted in retail, travel, dining, entertainment, banking, and other industries that we're all familiar with. And it's on demand and instantly executed. And the data are available to each individual through biosensors, images, lab tests, genomic sequence. It's accessible, it's analyzable, and it's transferable. So we now live in a world where more people have mobile phones than clean toilets. And with our smartphone, we can capture real-time biosensor metrics, capture images of the eye, perform various components of the physical exam, and we can even run laboratory tests. We can use our iPhone and obtain fundus images and images of the optic disc that can be analyzed very much like we have done in the past with very complex, expensive imaging devices in the clinic. We can go into developing countries where there is no eye care and begin to acquire information and begin treating patients remotely. Well, what about functional testing and visual field testing? Well, you probably feel like I do, and like most of our patients do. They don't like visual field testing. Well, that's going to change too. We already have several virtual reality devices for performing visual field testing, and this will be taken out of the office, and it will be done by patients at home. And we can, instead of getting a visual field test once a year, patients could be doing these daily or weekly. You've already heard from Kaveh Mansouri about implantable intraocular pressure monitors. Imagine collecting thousands of measurements of pressure on our patients. And the most remarkable thing about all this is this information can be transferred automatically to a handheld device, your own cell phone. And then finally, we have new measurements for obtaining information about whether patients are adherent with their medication. With this device that we developed, we can wirelessly transmit to the cell phone every time the patient takes an eye drop and send them reminders about whether they're taking their eye drops or not taking their eye drops. And with all this information, drug delivery devices and surgical technologies to lower intraocular pressure will be integrated with 24-hour intraocular pressure monitors. And we'll be able to adjust our treatment based on intraocular pressure values throughout the day, rather than the very crude snapshots that we obtain once or twice or even 4 times a year in our patients today.
We'll also have treatment of our patients and management of our patients that'll alter their lifestyle. Increasingly, there's information about physical activity and exercise being associated with slower visual field loss in glaucoma. This might mean increased walking or increased time spent doing moderate to vigorous physical activity. We'll also perhaps be doing things like meditation. This is a fascinating bit of work done by our colleague in Delhi, Tanuj Datta, showing how meditation can reduce intraocular pressure. And then finally, we'll be treating glaucoma, very much like they do for hypertension or cardiovascular disease, with changes in diet. Changes in diet. For example, we've learned that those consuming the highest amounts of nitrates from green leafy vegetables have a very significantly reduced risk of glaucoma. Well, where does it take us? Well, here's the future of glaucoma care. I think it's going to involve diet, nutraceuticals, Eastern medicine. We'll still have pharmaceuticals and generics, but it'll also include fitness and supplements and devices. Clearly, the future of glaucoma care will not be what it used to be. Simple quantitative data will be recorded, processed, and quickly returned to both the doctor and the patient. And there'll be monitoring in the safety of your own home with the resulting reduced expense and convenience. Patients having so much of their information will make transfer of authority possible. The authority will change from the physician to the patient. And the transformation will be the diminished dependence on all healthcare professionals in favor of the patient's relative autonomy. So let me conclude with some questions. Here's a big question. Will eye care and glaucoma care reboot and bypass deeply ingrained doctor-dependent operations? And then the final question, if we can build self-driving cars with sensor and computing technology, are we ready to develop doctorless patients? What does this mean for you? And what does it mean for our patients? Once again, I'd like to congratulate the Argentinian Society of Ophthalmology on your 100th anniversary. And I bring greetings from San Diego, California. Thank you very much.
Thank you, Bob. This was a fascinating talk.
Wow.
A bit frightening. I hope patients will still need us, at least for the next few years. And actually, I have a question. We have seen technology advanced so rapidly in terms of, I mean, it looks like light years, but things are happening very fast, and there is a lot of information to learn and to acquire and to apply. My question is, how fast do you think these changes are going to come? Is it going to happen in the next 5 years, 10 years? What's your vision on this?
Well, of course, Fabian, no one knows the answer to that. It used to be said that it takes about 17 years from an idea to bring something into clinical practice. However, as you point out, the speed of change is accelerating. And I think changes can occur within 5 years. I think, for example, genetic testing will be rapidly adopted if it can provide us advantages for diagnosis and progression. I think the use of new technology, smartphones, for obtaining, acquiring new information and translating that information also will be rapid. I think our ability to use deep learning in our practice for diagnosing disease and detecting progression of glaucoma will also be rapid. It will depend on our ability to obtain sufficient amount of data from patients to get meaningful responses. So things are changing quickly. I'm never surprised anymore when I wake up and I hear something that has been a new advance in medicine, a new advance in ophthalmology, something that was completely unexpected. So I think the only thing that we can expect in the next 5 years is the unexpected.
Thank you. Hector?
Thank you. I'm amazed with this presentation. Thank you so much. I have almost the same question as Fabian. We don't have when that is happened, but I think it's soon. And I have just a question about that. And what is the role of the neuroprotection now in the treatment of glaucoma for you? Where are we?
So it depends. That's a great question, Javier. Thank you very much. So neuroprotection is something that we've been interested in now for 30 years. And around 1991, Len Levine and I wrote an editorial in the Archive of Ophthalmology that first proposed neuroprotection for glaucoma. And it's something that we've dreamed about ever since. In the laboratory, we have many drugs that appear to be neuroprotective. However, demonstrating in a well-designed, sufficiently powered clinical trial that these drugs that are effective in the laboratory are effective in our patients is quite a challenge. It's very costly. It requires many patients. At the current time, we do not have a neuroprotective agent for glaucoma that I'm comfortable saying has been validated in an adequately powered and designed clinical trial. I expect that we will develop better endpoints for clinical trials, and there are several clinical trials that are ongoing. So again, I think that in the future, we will have neuroprotection. I don't expect that this will be tomorrow, but I do expect that in the future, we will be able to provide neuroprotection treatments to our patients. I don't think that they'll be independent of lowering intraocular pressure. So the same types of medical therapies and surgical therapies that we use today will continue to use, and neuroprotection will be complementary to those therapies.
Okay, that's great. Thank you so much.
Okay.
Bob, thank you. And going back to the topic of your talk, Chast, I want you to continue doing the outstanding job that you and your collaborators do at International Glaucoma Review to let us know all the updates that are coming in this new topic. I mean, there's a new topic regarding to technology, new technologies, wearable technologies, artificial intelligence, because the information is so huge that it's so difficult for us to keep up with the new papers, and having them in IGR is such a great service that I want to thank you for that.
Well, Fabian, thank you. But I hope you don't mind a shameless plug for the World Glaucoma Association, because under Fabian's leadership, we're hoping that very soon we'll be rolling out a webinar series where we could be bringing to our colleagues throughout the world the latest information about glaucoma, both for your clinical practice and also understanding the basis for the disease. So please stay tuned, keep in contact with Fabian Lerner, and we hope to see you all on these webinars.
Thank you very much. Thank you very much.
My only regret, Fabian, is here I am in La Jolla, having a wonderful summer in San Diego, And my only regret is I have great memories of many visits to Buenos Aires, where I could spend time with Roberto Sampalesi learning about childhood glaucoma, Alejandro Gonella, and Fabian Lerner. A beautiful city, a wonderful country, and fantastic people. Congratulations again.
Thank you very much. Thank you.
Thank you very much.
Bye-bye.
Bueno, buenas tardes. Ante todo quiero sumarme a las felicitaciones por los 100 años de la Sociedad Argentina de Oftalmología y quiero agradecerles en nombre de la Asociación Argentina de Glaucoma el habernos convocado. Finalmente quiero agradecerte, Fabián, por tu generosidad y por haber permitido que estas presentaciones sean posibles. Realmente esto implicó una logística importante de coordinar horarios, coordinar presentaciones y tanto el comité científico con Ana como representante como vos, Fabián, hicieron posibles que tengamos 7 presentaciones que por cuestiones de tiempo hemos presentado 5, pero quiero dejar bien claro que on demand ustedes pueden encontrar 2 presentaciones impecables que no tienen que perdérselas a cargo de Niru Gupta y Gustavo de Moraes, para lo cual las vamos a discutir a continuación con el doctor Ignacio Lichinsky de Tucumán y la doctora Ana Sansó. Así que, sin más, quiero preguntarte, Ana, ¿qué opinás de la presentación del doctor Liebman en relación a esta pandemia que estamos viviendo y el manejo del glaucoma?
Gracias. Es muy importante los comentarios del doctor Liebman porque remarcó algo que para nosotros es fundamental, la educación. En tiempos de pandemia, un tiempo que para muchos consideraban muerto, el proceso educativo tiene que seguir y tuvo que seguir. Fue parte necesaria para la construcción de todos los servicios y de todos los centros. Y no para olvidar a los jóvenes que debían continuar su formación y no pensar que era un tiempo muerto. Y sostener la moral, que eso es una de las cosas que también él hizo mucho hincapié. Definir la necesidad de sostener el ánimo de aquellos que están en primera línea y además quieren continuar con su formación. Entonces, destacar educación, de los cuales nosotros somos responsables, sostener la moral, nuevas adaptaciones a las formas de trabajo y a los espacios, que involucra además la incorporación de tecnologías. Creo que él hizo un interesante resumen sobre esto que vale la pena sentarse a desglosar parte por parte.
Buenísimo, muchas gracias. Quiero invitar ahora al doctor Ignacio Lichinsky, que nos acompaña desde Tucumán. Quiero preguntarte, Ignacio, si tuvieras que clarificar o transmitir a quienes nos están escuchando tus apreciaciones sobre la clase magistral de Kawe Mansuri, ¿qué nos dirías? No lo estamos escuchando, ¿eh? Sí. Por favor, Ana, mientras solucionamos este problema, quiero que nos digas qué te pareció lo de Gustavo de Moraes acerca de estructura-función.
Es una charla que no se dio, pero que realmente vale la pena verla, porque toca un tópico que es muy importante para nosotros, que es estructura y función. Esa famosa discusión de, ¿qué vale? ¿Estructura o función primero? Y en realidad las dos son importantes, y eso es lo que destaca de Moraes en su presentación. Yo no tengo que descuidar el aspecto estructural de mi nervio óptico y capa de fibras, ni el aspecto funcional, y cómo correlacionar y buscarlos, además en simultáneo, tanto la identificación precoz en el campo visual de los signos precoce, la modificación de punto a punto que él hace, el análisis puntual, y su correlato estructural con un buen estudio de OCT. Entonces él lo que destaca es estructura y función de la mano. Hoy por hoy el hallazgo, el valor clínico del análisis topográfico de tanto el campo visual como el OCT para la correcta valoración de la progresión en el daño glaucomatoso. Y la importancia en el futuro de la aplicación de algoritmos tecnológicos que nos van a permitir encontrar estos cambios de manera más normatizada y sencilla. Creo que esos son los tips claves, pero que no pueden perderse de ver esta charla.
Perfecto. ¿Está ya el doctor Lichinsky conectado? Perfecto, Ignacio. Recién Ana puntualizó los elementos más importantes de la presentación de Gustavo de Moraes. Como están en cierta forma relacionadas, me gustaría que nos comentes qué te pareció a vos lo dicho por Joel Schumann.
Schumann habla sobre las anormalidades de la estructura que ocurren antes que los cambios que suceden en el campo visual. Puntualiza muy bien de que en los glaucomas tempranos vamos a obtener resultados antes en los campos, antes en estructura y luego en un glaucoma muy avanzado en donde la perimetría va a tener mayor validez. De hecho, habla de unos reportes que podemos en los glaucomas preperimétricos llegar al diagnóstico 2 años antes con estructura y en los glaucomas ya perimétricos 1 año antes que los cambios en el campo visual. Enfatiza el uso de que tenemos que tener todos nuestros pacientes que vamos a monitorear en el tiempo, de tener el campo visual, de tener el OCT de mácula y el OCT de capa de fibras nerviosas. Y habla sobre la inteligencia artificial de una forma muy interesante, cómo es capaz de analizar las cosas mejor que lo que podemos analizarlas hoy y llegar a ver cosas que nosotros no estamos viendo en el barrido en crudo que se utiliza con el OCT. Por lo tanto, vamos a seguir aprendiendo cómo leer OCTs en el futuro.
Del aprendizaje a partir de las máquinas es un tema muy interesante y es lo que se viene hablando últimamente muchísimo en todos los congresos. Ana, ¿qué te parecieron las consideraciones de ICAMED en relación al manejo quirúrgico del glaucoma dependiendo del target que uno necesite para cada paciente?
Como sabemos, que es impresionante, siempre tiene una claridad conceptual inigualable, pero acá es muy importante. De toda la variedad de cirugías que él las expone muy claramente en sus presentaciones, bleb o no bleb, o sea, ampolla sin ampolla, técnicas que puedo hacer, lo importante es, si yo necesito bajar mucho la presión, o sea, lo que llaman alrededor de 10-12 milímetros de mercurio, sigue siendo la trabeculectomía la técnica hoy por hoy que ocupa un lugar todavía preponderante en el grueso de las situaciones de glaucoma. En cambio, si yo puedo estar en un paciente donde el target, eso es lo que llaman los mid, o sea, la mitad, 15, el más menos ahí, todo el resto de alternativas quirúrgicas ocupa un sitio donde podemos discutir una u otra técnica en función de la habilidad manual. Lo que es muy importante, y él enfatiza este concepto, que es no elegir una técnica por sí, sino elegirla comprendiendo la fisiopatología de ese glaucoma. Es decir, yo necesito entender dónde está la falla para poder elegir el método quirúrgico adecuado. Es decir, ¿funciona mi canal de filtración? Presión venosa episcleral, Schlem, trabeculado, puedo hacer procedimientos de canal. Si lo tengo estropeado, no me voy a meter a hacer un procedimiento de canal simple. Entonces, entenderlo conceptualmente me parece la clave para que uno como cirujano elija los procedimientos adecuados.
Genial. Y bueno, Ignacio, te pido otra vez tu opinión. Realmente la presentación de Niro Gupta nos aconseja varias cosas, pero fundamentalmente una, porque echa luz a lo que es el proceso de daño desde el ojo hasta la corteza occipital. Me gustaría saber tu opinión al respecto.
Bueno, Niro Gupta da una charla fantástica porque nos hace un repaso de todo el daño desde el nervio óptico hasta la corteza visual. Nos muestra 2 modelos de glaucoma y cómo se retraen, se encogen y cómo mueren las neuronas en el glaucoma desde el primer momento que empieza el daño en el nervio óptico y eso tiene un impacto visual en el paciente. Y nos habla muy interesantemente sobre un nuevo modelo que estudia sobre la circulación del líquido cefalorraquídeo y cómo descubre que no solo el líquido cefalorraquídeo está en el espacio subaracnoideo rodeando el nervio óptico, sino que es capaz de entrar y tener tiene una entrada al parénquima del nervio óptico. Por lo tanto, tiene una relación muy importante en lo que va a ser la salud de ese nervio óptico y en un nuevo sistema que sirve linfático, que es un sistema que sirve para la actividad de limpieza de las proteínas nerviosas, del nervio óptico. Por lo tanto, hace un cierre muy interesante que cuando dormimos es cuando este sistema tiene más actividad y que, bueno, creo que ahora podremos dormir un poco más con menos culpa porque nuestro sistema se protege y se limpia cuando dormimos. Muy interesante.
El título de nuestro simposio, Glaucoma, el futuro es hoy. ¿Es hoy el futuro? Bueno, si no es hoy, viene pronto. Y el doctor Weinreb empieza hablando de una frase que él acuñó, que es Smart Glaucoma, que es una especie de medicina inteligente. Y hacia eso estamos yendo y cada vez más rápido. Y la medicina es inteligente ¿y cómo va a ser más inteligente? En diferentes aspectos. En principio habló de hacerlo esto a nivel diagnóstico, y hay diferentes dispositivos como para hacer diagnóstico, inclusive basado en nuestros teléfonos. Habló justamente también del mismo tema al cual se refirió el doctor Mansouri, de la posibilidad de hacer registros de medición de la presión intraocular en 24 horas y tener rápidamente esas mediciones en un teléfono y transmitírselas directamente al oftalmólogo. Habló también de medicina inteligente en lo que respecta a tratamiento y saber mediante genómica y el uso de inteligencia artificial y Big Data exactamente cuáles son los medicamentos que más efecto van a tener en cada uno de los pacientes. Eso nos va a permitir hacer una medicina más individualizada. Y por último, también se refirió al uso de las tecnologías y justamente comentó algo que es verdaderamente cierto, que es el hecho de que hay más teléfonos inteligentes que personas con baños limpios en su casa. Y eso sucede también en la Argentina. Hay más teléfonos móviles que hogares con cloacas. Y realmente eso hace que haya mucha gente con un teléfono capaz de recibir información y brindar información inteligente acerca de su glaucoma y del resto de las enfermedades que hacen la práctica de la medicina. Muchas gracias. Espero que hayan disfrutado este simposio, tanto como lo disfrutamos nosotros, y de hecho va a estar on demand a partir del sitio de la Sociedad Argentina de Oftalmología. No se lo pierdan, es un simposio para verlo y volver a verlo y aprender mucho de glaucoma para nuestra práctica clínica y para un futuro que se viene muy rápidamente.
Ana.
Gracias a todos por la participación, gracias a todos nuestros oyentes por haber estado activos y conectados en esta transmisión, compartiendo estas maravillosas presentaciones y este panel de expertos. Pero quiero recordarles que el martes 8 es el gran día, a las 19 horas está el acto de clausura. ¿Qué significa eso? Es el acto donde vamos a cerrar este cumpleaños. Los que han recibido ya una botellita de champán tienen para el brindis, 19-15 horas de ese día. Serán las palabras de fin, la entrega de premios, y los queremos por favor todos conectados para compartir esta fiesta que es de todos. Y bueno, bienvenidos y a disfrutar de estos días maravillosos. Gracias, y en nombre de la comisión que organizó este evento y de la comisión de la Sociedad Argentina de Oftalmología, nos estaremos viendo todos estos días. Un saludo.